All right, good afternoon, everybody. This is the start of our voiceover for mood disorders. One thing that I want you all to be aware of is that many times people will also use the word affective disorders, A-F-F-E-C-T-I-V-E, in exchange for mood disorders. For example, you might, in a larger city or a university hospital, you might see a specialized unit called the affective disorders unit. That means that unit is specializing in people who have mood disorders, okay, depression, bipolar, that sort of thing. Or you might see somebody refer to this person has an affective disorder. Okay, that's what they're talking about, a mood disorder. It doesn't describe which mood disorder they have, but that they have a mood disorder. Okay? So let's go on to our first slide. All right, unipolar disorder. When we think about unipolar disorder, if you have two different poles, all right, the unipolar disorder basically is talking about major depressive episode or a major depressive episode, or a major depressive disorder, sorry. That means that there are individuals who may just have one major depressive episode in their life, and they may never have another episode as long as they live. Okay, there are those people who just have one episode in their whole life. There are other people, though, who might have a disorder, and so those episodes might be recurrent. They might have an episode of depression, and then they're treated for that, and they are doing fine, may be able to go off their medications for a year or 2 years, but then the depression may come back, and that might be kind of a routine for them. So maybe they've had 3 or 4 or 5 major depressive episodes in their life, okay, and then that is when we would then start to call that a major depressive disorder. When we're talking about depression, I just want everybody to be aware of is that, you know, when we talk about a mentally healthy person, a mentally healthy person can have a depressed state. That would be such as a brief, anticipated, and it may be very appropriate to have a depression. For example, if you have a death in the family, you may have, like I said, a depressed state. It may last a certain amount of time, and that may be very appropriate. This is not necessarily, you know, what we're talking about. Or you might be blue for 2 or 3 days, or, you know, might be blue and down for a period of 4 or 5 days. That's not really what we're talking about here, okay? Just to be aware of that. Now, as I go through these slides, I have a lot more on my outlines than I do on the slides, so you're going to have to be looking at both of these. So, when we're diagnosing unipolar depression or depression, and the DSM-4 and the DSM-5, they have special criteria that they are checking off before they can diagnose somebody with depressive disorder. So what they say is that depression is diagnosed if it persists over a period of time and it interferes with the daily functioning for at least 2 weeks. All right, if it lasts for 7 days and then the person is not depressed anymore, we would not call that a depressive episode or depressive disorder. Okay. The DSM-4 and 5 also say that besides that depressed mood, which lasts over 2 weeks and interferes with daily functioning, that there also has to be 4 other criteria or 4 other symptoms that go along with that before we can diagnose that. And again, they would say that those symptoms have to cause distress and impair the person's functioning. Okay, so let's look at symptoms that I have down on your outline. There's in your book on page 365, there's a figure 17.1 that goes through a lot of these symptoms, and they have it on a really easy way that you can memorize these. But let's look at these symptoms. Anhedonia. Now, where have you heard that word before? If you said that you heard that word from a negative symptom of schizophrenia, one of the 5 A's, you are exactly right. So anhedonia is obviously a symptom of depression. That's where activities are no longer pleasurable. They no longer get joy out of things that they used to get joy out of. Another symptom, vegetative signs and symptoms. This is a term which includes changes in physiological functioning. You will often hear other disciplines, especially psychiatry, physicians, refer to these symptoms as vegetative symptoms. And if we're going to be communicating and know what people are talking about, we need to know what vegetative signs and symptoms are. One good way to remember them, like I said, is a change in physiological functioning. First one here is appetite. Now, if I asked you, what do you think is the most common? What do we usually see when somebody is depressed? What happens to their appetite? Decreased is the most common. A person's appetite becomes decreased. However, there are those people who, when they are depressed, have an increased appetite. Sleep is another vegetative symptom. Again, what's the most common? If you answered insomnia, you are exactly right. That's the most common type of sleep problem that we have with people who are depressed. However, we also see those people who have hypersomnia, who sleep a great deal of time with depression. But insomnia is going to be the most common. 3 types of insomnia that I want you to know about: initial insomnia, middle insomnia, and terminal insomnia. Okay, we distinguish what type of insomnia that a person has, and the main reason that we want to know what type of insomnia they have is that there are certain medications that might help more with the initial insomnia, or some medications that are going to help more with terminal insomnia. Now, initial insomnia, as you can guess, is where it's difficult to fall asleep at night. You just can't fall asleep. Middle insomnia, you're able to fall asleep, but then you might wake up in the middle of the night. And whatever that is for every individual is different. But you wake up, say at 2 or 3 in the morning, all right, and then you cannot get back to sleep. Then we also have terminal insomnia, and that is where a person's able to fall asleep. They stay asleep for a pretty good time, but they wake up in the early morning hours and cannot fall back asleep. So for me, I go to bed at 10 o'clock. I usually wake up about 6. So terminal insomnia for me might be 4:30 in the morning, something like that, roughly about that time, and I just cannot get back to sleep. Okay. Another symptom for vegetative symptom is weight loss. That is the most common. Again, we could have a person who is gaining weight as a symptom of depression, but most typically we see weight loss. When we're talking about weight loss, we're not talking about, oh, they lost 4 pounds last month, or they lost a couple pounds, because that we're talking about a significant amount. We're talking maybe 12 pounds in the past month, and they're not trying to lose weight at all, or roughly around there. It might be a little bit more. So it's not just a pound here or a pound there, but it has to be a substantial amount of weight loss. We also have as a vegetative symptom decreased interest in sex. Some people will call that decreased libido. That's kind of an old term that we hear, and you don't really hear that anymore, but just a decreased interest in that, or a lowered sex drive. Okay, other signs and symptoms of depression, major depression. A person may describe their mood as depressed, sad, down, everything that I have down there, helpless. Sometimes you'll hear people say they have no feelings at all, or that they are very irritable. And you may even run into people who say, I just don't know how I feel. There are some people, typically men, we could say, but not always, that are socialized not to focus on their feelings or not to be aware of their feelings. So maybe if you're interviewing a male and they don't say that they're depressed, or they don't say that they're down, that does not necessarily mean that they do not have depression. Okay, because sometimes we are socialized not to focus on what our feelings are, or not even to be aware of what our mood is. Another symptom: multiple physical and somatic complaints without a real cause. So if a person's had all these headaches and they've been worked up for headaches and there's no real reason why they might have headaches, or any other somatic complaints, stomach aches without a real cause, those could be a symptom. Psychomotor retardation or psychomotor agitation. That psychomotor retardation is when a person is just very, very, very slowed down. You can see that in the way that maybe they are moving. If they are doing any task, it just takes a very, very long time for them to do it. Everything is just slowed down. Or it might be that you hear when they are talking, they just talk at a low voice, but also they slow their words down and just don't talk very fast and everything is slowed down. Or we could have psychomotor agitation, which is a person who's fidgeting, just kind of agitating, maybe can't sit still. Okay. Fatigue and excessive fatigue is another symptom. Decreased energy, don't have the energy to do things they used to do. The fatigue and the decreased energy, sometimes people call this anergy, A-N-E-R-G-Y. This is a very common symptom where they just don't have the energy that they used to have, and it interferes with getting things done in their life. As I said, this is very common. Sometimes we see people say that, you know, they have a good 8 hours of sleep, but they wake up just feeling exhausted or tired, and that everything takes a great deal of effort. Sometimes people have guilt or exaggerated self-blame. They feel guilty for everything that they've done, and they are almost hypercritical of themselves and feel hyper guilty about things that they have done and do a lot of self-blame. Oh, I'm not doing a good job with my kids. I should have done this. Or I'm not a good wife. I should be doing this. But a lot of guilt or blame. Worthlessness, feeling like they're not worthy as a person, maybe to be in a relationship, to have the things that they have, that there's no reason to continue with things because they feel worthless. Hopeless and helpless, another symptom that there's no, you know, I just feel so hopeless. What's the point of finishing school? I feel so hopeless. What's the point of getting out of bed? Hopeless about any areas of in their life. Helplessness, meaning that no matter what I do, it's not going to help this depression. You know, if you say they feel helpless, if you say, well, why don't you try to do some volunteer work, or why don't you try to do this or that, they just feel, no, that's not going to help. There's no way that I can help myself to feel better. Okay. Decreased concentration and memory, again, very common. Things that may have been very easy for them now takes like extra concentration, and they have troubles with their memory. Suicidal ideation can also be a symptom. And suicidal ideation, meaning they're having thoughts, that's the ideation, thoughts of wanting to hurt themselves or to kill themselves. All right. Now, just to be clear, is that there is, besides the thought, suicidal ideation, the thought of wanting to hurt themselves or to kill themselves, is another type of suicidal ideation where the person has feelings of just not wanting to live anymore. They may not have the actual thought or plan of killing themselves or the actual thought of doing something to themselves, but many times people will describe it as, I just want to go to bed and never wake up. Or I just wish I didn't have to go through this day-to-day living. I just wish I wasn't alive. Okay, so we have, when we're and we'll talk about assessment later on, but we do have to distinguish what kind of suicidal ideation they are actually having. So again, if we went back to the DSM-4, we know what the definite or the criteria is. They have to have, you know, that depression that persists over time for at least 2 weeks, and that interferes with daily functioning, and then at least 4 of these other symptoms, okay, that I've just listed. Okay, so just because you don't have to have suicidal ideation to have major depression, and there's many people who do not have those suicidal ideation. Okay, so but any 4 of those. I do want you to take a look at, in your book, there's an example on page 364, and I'd like you to go through that and circle all the symptoms that you see of depression. All right, and then we'll try to talk about that in class and see if you have those circled. It's relatively easy, but I want you to just kind of practice recognizing what those are. Okay, I also have on here a website, or a site on here that shows a psychiatric interview of somebody who is depressed. They go through the assessment for depression, but they also do an assessment of suicide, and then they do spend some time explaining treatment, that sort of thing, to the patient. Now, this lasts about 15 minutes, so it is it's kind of long, but if you have the time, I would encourage you to look at that, because it is just a good example of asking questions, but also seeing how that is evidenced in somebody's life, those symptoms. Okay, you can also see how a person is slowed down, what a depressed affect looks like, what a depressed mood looks like. Okay, so that is good to look at. So that's one of the unipolar disorders. We're going to go to the next slide, and we are going to look at another unipolar disorder, which is dysthymic disorder. This disorder is where a person is chronically depressed, or they have a chronically depressed mood for the majority of days for at least 2 years. Now that's kind of a weird way to give a definition, but that is how the DSM, the terminology they use. So that's not my terminology, but that's what they use. Okay? So, dysthymic disorder, although it's a depressed mood, it's the depressed mood and the signs and symptoms are much less severe than major depression. That you might have, any one of those, symptoms that I just listed above, but they're going to be less severe. There's going to be less physiological or less vegetative symptoms. We find dysthymic disorder more in women. And also dysthymic disorder can be very difficult to diagnose, but the nursing care is going to be very similar to major depression. So just a little bit more about dysthymic disorder. I kind of refer to it as a low-grade, if you will, depression that exists in people's lives. Many times they are able to function. They can still go to work. They can still go to, function at a decent level. But you will hear them describe, this is just something that I feel was part of my personality, or it's just I'm trudging through life, that sort of thing. Almost like, it could be, that they have a black cloud, over their life, or this is the person that just always seems kind of down, or Eeyore, if you remember that from Winnie the Pooh, that kind of thing. Now, sometimes people, because they've lived with this many times in their own life and they have never been diagnosed with it because, they haven't, it hasn't interfered with their life, so they may not think about going to a doctor to be treated for it. Those people that may have decided that, I do want to go to a doctor, and they're diagnosed with dysthymic disorder and they're treated, many times they will say, oh my gosh, I wish I would have gone to the doctor 3 years ago or 10 years ago to get treated for this. I just didn't know I could feel good. I just thought this dysthymia was just a part of my life, and that was just my personality, and that's just what I had to live with. And they didn't know that they were really depressed. Okay, but many times when they receive treatment, they are amazed at how much better they do feel. Okay. The next disorder here is seasonal affective disorder, and I'm not going to spend a lot of time on that. That's also abbreviated SAD. This is a depressive disorder that occurs, and you guys probably have heard of this, occurs in relationship to the seasons. It's usually in the winter months, and a lot of research is being done, but there's a relationship between light and the seasons and the biological rhythms of a person and their mood. And so there is a lot of research being done with that. I'm not going to be asking any questions about seasonal affective disorder, but I do want you to know that it's out there, and we do see people coming in for treatment with that. Okay, the next slide is talking about bipolar disorders. Bipolar disorder is a group of mood disorders which include manic episodes and include depressed episodes. Bipolar disorders usually begin in the early 20s, but they can happen at any time, but most typically we see them in the early 20s. And usually we see a person's first break, if you will, when they are under a lot of stress. And usually a lot of stress can kind of bring out this first episode. Okay, and when I worked at the University of Iowa, it was very interesting, but oftentimes at the beginning of the school year, and oftentimes when sororities and fraternities were rushing, and that I guess, I haven't been in a sorority or fraternity, but what they have told, that it's just a really stressful time for students when they're rushing these. They don't get much sleep. They're going to all these parties, doing all this kind of stuff, and they want to get into the frat or sorority that they want to, and they just feel a lot of pressure. It's amazing, but every year it seemed like we would see one or two students who would have their first manic break, and many times they were, in the beginning of the school year, and they also were rushing these fraternities and sororities, and they said that that did make them under a lot of stress. So I just think that's interesting. No study that has been done or anything with that, but just interesting. Okay, bipolar 1 and bipolar 2. Bipolar 1 is one or more manic or mixed episodes, usually with a depressed episode in there somewhere. So, what I like to think about bipolar 1 is that there's more manic episodes, but in order for it to be a true bipolar 1, you have to have a depressed episode in there somewhere. So you might have a person who has their first break and they have a manic episode, okay, and they come into the hospital. They would probably recognize that as a manic episode and be treated. They wouldn't necessarily call them a bipolar 1 until the person had a depressive episode along with that, okay? And just a side note, many times, bipolar in the olden days, if you will, was referred to as manic depressive episode, but we no longer refer to it as that. You might hear a lot of people say that, but it's bipolar disorder. So we have two poles, okay, that a person fluctuates between: a mania, which is a high, and a depression, which is a low. Okay, so that's bipolar 1. Bipolar 2 is one or more major depressive episodes accompanied by at least one hypomanic episode. So bipolar 2, again, I like to think of it as more depressive episodes, but again, in order to be diagnosed with that bipolar 2, you have to have at least one hypomanic or manic episode somewhere in a course of time. So it could be that a person has a major depressive episode. They probably wouldn't be diagnosed with bipolar with just that depressive episode. They'd be diagnosed, especially if it was their very first one, they would probably be diagnosed as major depressive episode, especially if it's the first one. If they have another depressive episode, again, they probably continue with that major depressive disorder as a diagnosis. But maybe in 2 years or 6 months, whatever the case might be, that person then might have a manic episode or a hypomanic episode, and they come into the hospital or they talk with the doctor about it. That is when then they might be given the diagnosis of bipolar 2. So you can see that in order to have an accurate diagnosis, sometimes we have to wait for a period of 1 or 2 years to see what is happening with this person. So a person might start out with major depressive disorder, but then in a year or two, their diagnosis might change to bipolar 2. Okay? That doesn't mean that the doctor is a bad diagnostician, but just that we haven't seen that hypomanic or manic episode yet. Okay? And as we're going along here, you guys, star anything that I'm saying that doesn't make sense, or star anything that you have a question about, and then we can talk about it in class. All right? So I talked about bipolar 1 and bipolar 2. Okay, and we've already talked about those depressive episodes. Now I want to talk about manic and hypomanic episodes. So a manic episode is where a person has an elevated, expansive, or irritable mood. And again, the DSM says that has to last for at least 1 week. All right? So elevated meaning they're feeling really good, really high, if you will. Expansive meaning just, again, that's kind of another word for feeling elevated, high, just really expansive mood. And this is one thing that some people don't realize, or it can be a very, very irritable mood. All right? And the key thing here is that it's abnormal from what their normal mood is, and that it's persistent, meaning that it's lasting a week or longer. And this mood has to significantly impair social or occupational functioning. So this mood then gets in the way of them working or holding a job or having a relationship with somebody or taking care of their family. Okay? And the DSM then says that it has to be accompanied by at least 3 additional symptoms that are listed below on your outline. These symptoms are an exaggerated self-esteem. This is when the person feels like they are the best at everything. They'll tell you, and they'll tell you about it. They're feeling great about themselves, just feel like they're almost on top of the world. They think everybody loves them. They may feel that they are very superior to other people. and that other people just don't get it. They just aren't quite where they're at. You know, I'm just superior to everybody. Okay, and it's very, very exaggerated. They might feel that they are the best, salesman that there is. And everybody else is just, barely, making it or cannot compare to them. And that could, be spread out to any, occupation that they might be at. Talkativeness. We often describe a person in a manic situation or a manic episode as hyper talkative. They just talk nonstop, and it's very difficult to interrupt them, and it's very difficult to get an answer to a question. These people usually are very social and are almost like social butterflies, talking to everybody, talking about everything. All right. As you'll see on your slide there, I do have a psychiatric interview with a manic patient. This interview I really do want you to watch because it is very good in really looking at a manic patient as far as this hyper-talkativeness and a lot of things that are going on here. So I really do want you to look at that. Pressured speech is another symptom, and that pressured speech is just where the person's thoughts are racing in their head, and the person is trying to, with their speech, is trying to keep up with their racing thoughts to, tell you or tell a person about these racing thoughts, but I just describe it as their speech cannot keep up with their thoughts, and they're just pressuring to get that speech out as much as that they can. So that pressured speech. Flight of ideas. That is where a person is jumping from topic to topic to topic. It's not necessarily loose associations. It's not, although they might have some of that, and it's not really like thought blocking or anything like that. But they're just jumping from idea to idea, and many times it's quick, and it's hard almost to follow them about where they're going with those ideas. Restlessness. They may have trouble sitting still because they are just so active and they want to get things done, and they are busy moving around and just very restless. Decreased need for sleep. This is a person who may not sleep for many days. They might take a cat nap here or there during the day, maybe for 30 minutes, maybe for an hour, but they really are not sleeping, having a night's sleep, 5, 7, 8 hours of sleep for many days. Some people will say it's a couple days, and it's almost hard to imagine that somebody could go 4 or 5 days without any sleep, but that's what we see many times. Grandiose thinking. This is where a person has these grandiose ideas, very, very large ideas, things that they, might not be realistic. For example, might not be realistic for that person, but they're just really, really big ideas. When you read in your book, there'll be some examples. I know that I worked with a patient, or when we had students over at Genesis a couple years ago. It was just fascinating to me, but one of the patients was manic, and she believed, in her thinking, it wasn't a delusion at the time, but what she wanted to do was design jewelry for Faith Hill and for Faith Hill's husband. And she showed us all this elaborate presentation of all this jewelry that she designed on a sketch pad and all this kind of stuff, and telling us how much she was going to charge for things, what precious stones she was having in each necklace or ring or that sort of thing. But it was this very elaborate, grandiose plan. It was just amazing, and how she was going to make millions of dollars with it and that sort of thing. So that's an example of grandiose thinking. Distractibility. They may not be able to keep on a topic, or they might be talking with you, and then all of a sudden they hear the door slam, and they totally change and look over at the door, and then they walk over to that person, start talking with that person, and get really involved with them. Something else happens, and they're totally distracted again. Increase in goal-directed activity. This is where maybe they are want to get something done, and maybe they are very good at getting it done because they have all this energy and can devote to it. I know that I've heard, some patients have said that, boy, when I'm in my manic stage, I can clean my house. I can clean for 24 hours, and their house is spotless, and they have just all this goal-directed activity. Or I've also had patients who have been students, graduate students, and they say, when I'm manic, I can really get those papers done, or I get a lot of my writing done when I'm in a manic stage because I can sit for a long time and get that, I can get that stuff done. Okay? They don't need much sleep, and they're just really focused on that goal-directed activity. Many times these people also have a labile affect. Labile means quickly changing. And so if you think about affect, that's what their emotions, or what emotions are being portrayed. So they might quickly change from being very, very happy and talking to you about something happy, and then all of a sudden they start crying because they thought about something sad. And so then they're very, very, sad and crying. And then they might change again to being happy. Or it can have the same thing with quickly all of a sudden becoming mad and angry and just flying off the handle. Okay, so it's this quickly changing, or labile affect. A person could have excessive involvement in pleasurable activities, which has the potential for painful consequences. Okay, so let's look at that again. Excessive involvement in pleasurable activities that can have a potential for painful consequences. So some of these it might be that the person is hypersexual, okay? So they get involved, and that hypersexuality causes them to get involved, possibly in a lot of pleasurable activities. But what is the danger of that if a person is hypersexual? Well, it could be that they're going into bars, having a lot of one-night stands, meeting people that they've never met before, which might be, questionable people. They don't know them, and again, like I said, having one-night stands. There's a lot of painful consequences that can result from that, such as STDs, potentials for sexual abuse, potential for rape, potential for a whole host of things that might have painful consequences. Okay, even if a person is hypersexual and they really enjoy flirting with people and all that kind of stuff, I've seen where a person being hypersexual at their job, they start flirting with their boss, or start flirting with a customer, and they get fired from their job. Okay, so that's a very painful consequence. A person who's a workaholic, okay, they enjoy their work, but now when they're manic, they just work all the time, and they never come home, but just work, 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 and they have that goal-directed activity. Painful consequence from that might be that their wife is getting mad at them and can't take it anymore, and maybe wants to get a divorce. Or maybe they forget to take care of responsibilities at home, or maybe forget to take care of, paying bills or something like that. Another example might be increased spending. Buying things. I mean, shopping, taking trips, all that kind of stuff is fun and pleasurable, right? But with a person who's manic, the increased spending can reach portions where they can become in debt, or very much in debt. They can become bankrupt. Spouses may want to divorce or leave the person who's overspending their money. Again, and when we going on shopping sprees, I don't know what your shopping spree is, but somebody's shopping spree might be $50 or $100. A person who is manic, you're talking thousands of dollars. Okay, and that's not something they would normally do when they were not manic. Okay, so it's very much against their character. So you're talking thousands of dollars, $5,000, $10,000, and it's usually may or may not be, but money that they don't have. So they're charging it on their credit cards. And not shopping, but maybe it's they're taking trips. So they fly down to Florida at the drop of a hat, and then they fly to another place at the drop of a hat. I've heard patients who have said that they, so manic that they would fly to New York for lunch and stay overnight and then come back to work the next day. Just, really wild things. And again, those painful consequences you can imagine with that. Okay, so now I have down here severe mania. Once a person is manic, okay, once they start to increase that mood and have these symptoms and have mania, there's always the danger that that person can go into severe mania. And severe mania, if it progresses, a person can become psychotic and have those, and you guys know what psychotic means, have those positive symptoms that we talked about with schizophrenia. So severe mania can lead to and will have a person who may be hallucinating, may be having delusions, may become very disorganized in their speech. Okay? So, and if that's the case, you can imagine that most of those people, once they get into that severe mania, that's a very, significant episode, and those people usually are hospitalized. Unfortunately, especially many times during a person's first break, that usually nobody is recognizing, these the beginning symptoms of mania. And so oftentimes they're not brought into the hospital or brought into a doctor until they are in a very severe mania and they're actually psychotic, okay? Where they might be, and we've seen this, walking out in the middle of the street naked because they don't know where they're at or what's going on, or they have some type of delusion going on or hallucination, and the cops pick them up and we realize that they're in a very, manic episode. Okay? All right. Now, the other term that I want you to know is hypomania. And this basically is, as you can guess, it's a lower level than mania. It's not regular mania, it's not severe mania, it's a lower level of mania. This is a less extreme form of mania. It's not severe enough to markedly decrease the person's functioning at a job or in a relationship, and there's no psychosis in hypomania. Okay? So many times people might start out hypomanic, and unless they're treated or get their meds changed or that sort of thing, that hypomania may increase to mania. And again, unless somebody catches it and they're treated for that, it might then go into severe mania, which then goes into psychosis. Okay? There are some of people, however, that they only have hypomanic episodes, especially like in that bipolar 2. They may never go into a severe mania, so just be aware of that as well. In your book, there's an example on page 367, and I want you to do the same thing. As I want you to circle the signs and symptoms of in that clinical example that you see of mania. And then we'll try to review that when we come back the next day. Slide. And look at depressed episodes. So we're still talking about bipolar disorder, where a person have the manic episodes. A person can also have depressed episodes. And as I said before, depressed episodes can occur in either bipolar 1 or bipolar 2. Many times these people will have had manic episodes in the past, and we treat these depressed episodes in bipolar very similar to how we treat regular depression, except the medications are going to be different. Okay? Mixed episodes. This is where a person has signs and symptoms of mania and depression present nearly every day for a 1-week period, and they may alternate. So a person might have, mania one day, depression the next day, and another time mania maybe for 2 days, and it's lasting for at least a 1-week period. Could, last longer. So we would call that person bipolar disorder with mixed episodes. Cyclothymic disorder is a type of bipolar disorder. This is where a person has has to have at least 2 years of chronic hypomania signs and symptoms and depressive signs and symptoms, and that goes in cycles. So it's very similar to dysthymic disorder, except it's with bipolar. Okay, and so it's less severe, and it's not interfering with work or relationships, but we can diagnose them with cyclothymic disorder. I forgot something on there. I want to talk about a few other disorders. We have postpartum mood episode. This is, you will probably be talking more about this when you get into OB and start talking about when you get into that class. But just a quick mention of that. This is postpartum episode may increased in women who've had prior mood disorders, but that's when after a woman has given birth and they have a major depressive episode. It's not just the baby blues, which most women do go experience, but they have, various symptoms of major depressive disorder within 4 weeks of giving birth. Okay, and many times they also have that preoccupation with the infant's well-being. Okay, and so you'll learn about that a little bit more and the importance of assessing that in postpartum women. Your book talks about mood disorder due to other medical conditions. And just be aware that sometimes, especially with substance abuse, many times people who are abusing meth, cocaine, alcohol will also have a depression along with that, okay? Or if you think about a person who is experiencing some kind of physical illness or chronic illness may also have a depression with that, so just be aware of that. The other one on here is bereavement, and I want you to know the definitions of these. Bereavement is a state of loss, and it's a natural thing, and that is where a person has something that is valued is no longer available to them, or it is gone, okay, and they go through a bereavement period, okay. And like I said, it's normal, it's natural when something you have that you value is gone. Okay, it might be a job, it might be an actual person in your life, it might be a death, but it might be a breakup of a relationship. It might be that you have an amputation of your leg or your arm. Okay, that is a loss. It might be that you have a chronic illness, heart condition, and you can no longer, have the same activity level that you had to have. Okay, but that is a loss. Grief is a feeling of sadness related to that loss. Okay, and it's more of a process, a grieving process. Dysfunctional grieving is where a person fails to go through the normal grieving process, and it deviates from the norm. The person often feels very, very overwhelmed, and they start to have maladaptive coping. Remember when we talked about, healthy coping mechanisms, but then we also talked about defensive coping. And defensive coping is that maladaptive coping. It might be that, they're using a lot of projection, or they're using, a wide variety of any of those defense mechanisms, but it's maladaptive. It's not helping them cope in a healthy way. It's not helping them to resolve the issue. It's not focused on problem solving and moving forward. That's maladaptive coping. If you don't know the stages of Kubler-Ross, stages of grieving, I want you to look at those: denial, anger, bargaining, depression, and then acceptance. Those are the normal stages of grieving that everybody goes through. Okay? If at any of those stages a person cannot resolve through that stage, it will not lead to a successful conclusion. Okay, and if a person is in dysfunctional grieving and can't go through successful conclusion of the stages of grieving, they will treat that similar to depression and treat the person for actual depression. They may not diagnose them with major depressive disorder, but they may be diagnosed with dysfunctional grieving. Okay. Now, this is not, I don't want you to think that this is the key, set in stone or anything. But some people will say that an average grieving process, going through all these stages of Kubler-Ross, that, 5 years, it's not unusual to have a person say that I have not got through those stages of grieving until about 5 years. Okay, so just keep that in mind when you're looking, when you're dealing with somebody with that. That might be more of an extreme, but that still would be in that normal phase. Many people will get through grieving in a year or 2 years, but if it starts to go on much beyond 5 years, 6 years, 7, that sort of thing, then we would also kind of look at the possibility of dysfunctional grieving. Doesn't necessarily have to be, because everybody is different and individual, but it could be. Okay, theories. Theories of depression and theories of bipolar. Okay, theories of mood disorders. What's going on here? First of all, we have the psychoanalytical theories. Again, we're talking about Freud and his colleagues. This again has focused mostly on the mother-child relationship, and that's the cause of why you're depressed, or that's the cause of why you have bipolar disorder. Again, as I've said before, that any more psychoanalytical theories and this focus on the mother-child relationship are very much criticized by mainstream psychiatry. It doesn't hold a whole lot of water. Okay. The next theory down here is cognitive theory, and you hear a lot about cognitive theory, very or not lately, but in the past 10, 15 years, is something that many people are using in treatment of depression. And cognitive therapy is something that nurses can do, and when you do specialize in psychiatric nursing, you learn cognitive therapy and cognitive techniques to work with your patients. Okay, so that you get a lot more specialization if you're a psychiatric nurse. However, you can use cognitive techniques in your coaching. You can use cognitive techniques in any area of nursing. A student that I had last semester, she did some cognitive techniques with her client for a behavior change, some thinking patterns, and it actually worked pretty successfully with that patient. Okay, so what is cognitive therapy? Cognitive theory. Cognitive theory would say that depression is secondary to or is caused by cognitive misinterpretation that involves distorted thinking. So what the heck does that mean? Okay, that's a lot of stuff. So basically, a person's depression is caused by a person's thinking, that their thinking is distorted, and that causes distorted feelings, if you will. And cognitive theory very much says that thoughts always precede a feeling. So I want you to think about that for a minute. Thoughts always precede a feeling. That's what this theory is saying. That if a person is mad or a person is depressed, that isn't automatic, or that just doesn't happen. But there's a thought, whether you're conscious of that thought or not conscious of it, there's always a thought that's preceding it. So maybe you fly off the handle and you're very angry. Well, they would say that you actually have a thought, maybe that, oh, that person thinks I'm stupid, or that person is disrespecting me, and you fly off the handle. That thought might happen so quickly, and so quickly you have a feeling right after that you're not even aware of that thought. Okay? But if you were to stop and examine it, we could identify a thought that's before the feeling. All right? So if a person has a lot of negative evaluations or a lot of negative thoughts of themselves or in the world, that is going to lead to negative feelings, which might be those depressed feelings or angry feelings. We also oftentimes call those negative thoughts irrational thoughts, that it's not rational, or sometimes we will call them cognitive distortions. And again, cognitive theory would say that all irrational thoughts, all cognitive distortions lead to negative or depressed feelings. So what is a cognitive distortion or irrational thought? We talked a little bit, I think, before about all or nothing thinking or black and white thinking, overgeneralization. Basically what this is that, for example, let's say flunked one test. That must mean I'm stupid. I'm never going to be able to pass any more tests. I should just give up. Those are thoughts, okay, and irrational thoughts, okay, and cognitive distortion. We could call that, kind of black and white thinking or an overgeneralization. So, of course, if a person's going to be thinking that way, I can't pass any more tests, I'm worthless, I shouldn't even be in school, that can lead to negative feelings, which can lead to depression, okay? Again, and that's what cognitive theory says that leads to that depression. So if you think about it, then what is the treatment? What would cognitive theory says, how can we treat this? Well, they would say if you correct the negative thoughts or the distorted thoughts, then that is going to lead to positive feelings, and then alleviate, that depression. So cognitive therapy basically is teaching individuals how to stop negative feelings and how to stop negative thinking and replace it with positive thinking. And then once you have that positive thinking in place, you're going to then develop positive feelings, and then you're going to have a decrease in depression. So, as I mentioned before, nurses do a lot of work with this with clients in the psychiatric field, but also in other areas of nursing. Okay? And if you're identifying any of these negative thoughts in your clients at work, or not at work, but in your clinical place, then you might want to talk to your instructor or talk to me about potential for doing some cognitive therapy with them or cognitive techniques with them. It can be very, very useful. And sometimes people aren't even aware that they have negative thoughts when they're depressed, or not even aware that they have negative thoughts when they're angry. Okay. I also want you to read over learned helplessness, and which is a kind of a type of cognitive disorder where the person feels like they have no control over their life, they have no control over their life situation, which again is a distortion, a distorted thoughts. People do have control over their lives. They do have control over situations in their life. They're just don't know how to think about it in that manner, and we call that learned helplessness. But many times those people will benefit from cognitive therapy. Okay, let's look at the biological theory then. And this is saying that there are biological factors that affect the brain that cause mood disorders. First of all, gender. More females are prone to major depression and dysthymia. And this is true across cultures, not just in North American culture. There may be other reasons besides that gender. There also may be inadequate support systems for women. Women may feel less powerful or have more learned helplessness. But anyway, we do know that with females are more prone to major depression. Age. We also know that elderly, especially elderly with physical illnesses, are more prone to depression as well. Genetic factors. There is an increased incidence in relatives of depressed individuals. All right? Bipolar disorder, it's increased among first-degree relatives. So again, because of these things that we have studied and know, that has caused us to believe that that there is a genetic component to it. Although some people, we could argue, is this genetic, or could this possibly be related to their environment? Okay, nature or nurture. But is it because you were raised by, in a depressed or learned helplessness type of environment, and therefore you've learned to have negative thinking, and therefore you are depressed? So that there's some controversy and a lot of discussion about that, but we do believe that there's a genetic component. And again, this is a biological theory. The biochemical theory is the biological factor neurotransmitter hypothesis. And there's the monoamine neurotransmitters that are in the limbic system are decreased. So those neurotransmitters are serotonin, norepinephrine, dopamine, and epinephrine. And those are all decreased, and what the hypotheses are all decreased in depression. Serotonin is one area where we spend a lot of time, and we do know that this is decreased in depressed people. We know that serotonin also has a role in behavior, and it has a role in mood, activity, also aggressiveness and irritableness. We know that norepinephrine is decreased also in depressed people. However, norepinephrine is increased in people with mania. And there's many, many other studies that are focusing on neurotransmitters. Like I said before, epinephrine and dopamine. And some recent biochemical research says that there's a definite relationship between psychosocial stress and the pathophysiology of depression. That if a person has chronic stress in their life, that this impacts the limbic system, which then impacts the neurotransmitters. So a lot of research that is being done in this area with the neurotransmitters. Now, one thing we know is that the monoamine theory is not sufficient to explain everything about depression or mania. It only explains that one aspect of the neurotransmitters. So there has to be further research, and people are doing more research on it. So it's not 100% effective in explaining depression, but it's there. Okay. And another fascinating area of study is trauma. How chronic trauma, when we could call that stress in a person's life, can cause depression. And there's a fascinating research that's being done with trauma and chronic trauma in childhood, and how that leads to tons of problems when a person gets older. Okay, psychological factors. I want you to read about those on your own on page 372, but what are psychological factors that make a person at risk for depression? Well, we know low self-esteem can. If a person has lack of goals or direction, if a person tends to avoid difficult situations, if a person is over-dependent or has dependency issues, those are risk factors. If a person is very passive in their life, that's a risk factor. If they're unable to form enduring relationships, another risk factor for mood disorders. And I do want you to read those sociocultural factors on your own. Okay? Okay, I'm going to go into the nursing process in the mood disorder. I'm going to get through the assessment phase and then through the suicide assessment, and then we'll be done. Okay, I want a quick note here that I have on your outline is that we are going to be using material from chapter 23 as well, chapter 23, and that chapter deals with clients at a risk for suicide and self-destructive behavior. So we're not going to cover that separately, but we're going to bring this into the nursing process. And obviously, you know, talking about suicide and that kind of stuff is a perfect fit here. So assessment, major depressive disorder. When we're assessing, subjective data, I've already covered that at the beginning of the slides. So all those things that have to do with the subjective manner would be listed here. I want to talk a little bit about suicide assessment. Page 516 and 518 in your book talks about that, and I want you to read that. There are people who have, or suicide assessment usually will start to look for clues or cries for help. And most people, again, you can't say it 100%, but many times people who are feeling suicidal send out clues or send out cries for help. And as your book says, almost all people with suicidal ideation let others know or have been in contact with before with the health system. There are many verbals that a person might say about being depressed or feeling alone or feeling isolated. And most people with suicidal thoughts want help, okay? And that's something that we can remember. But I want you to read that area in your book very carefully and add any notes that you need to there. We need to look at behaviors as clues. Again, page 517 looks at that. And I want you to know those bullet points, such as, you know, giving away prized possessions. You know, what are some of those clues? So I want you to take those notes down and to know those. Questions to ask. When we're talking about suicide, assessing for suicide, we have to ask directly. And usually the patient is very relieved that somebody has brought this topic up, that somebody wants to talk about it. Because in our society, really, suicide, wanting to kill yourself, is almost a, you know, there's almost a stigma to it. So people really, you know, they may feel embarrassed, or they may feel, you know, oh, I'm such a loser if I'm having these thoughts. So if somebody brings them up, many times they are very thankful that somebody else brings them up if the nurse is asking about this. So it's important for you as the nurse to know that even though, you know, when you first start out, you feel kind of awkward asking that question, but rest assured that it's an important question, and again, many times people are relieved that it's brought up. So, you know, that might be, you know, are you having thoughts of wanting to hurt yourself, or are you having thoughts of wanting to kill yourself? And a patient usually will answer that. I mean, 99.9% will answer that truthfully. There are some of the patients, more with personality disorders, who might not answer that honestly, but in most cases they will answer that, or like I said, almost 100% will answer that accurately or honestly. Once you find out that that person, let's say they say, yes, I have been thinking about that, your next step that you need to do is you want to find out if they have an actual plan or if it's just a vague thought. Okay? So you can ask, so you've been thinking about wanting to hurt yourself. Do you have a plan? Or tell me what your plan is. And they'll either tell you what it is, or they'll say, well, I don't really have a plan, but I've been just think I want to die, or I think I want to do something to myself. If they have a plan, usually they will tell you the plan. as I mentioned before, sometimes it's just a vague thought. Well, I don't know that I want to kill myself, but most of the times I just don't want to wake up in the morning. Okay, so that's more of a vague suicidal thought of not wanting to live. As I said before, always ask if they have access to a plan. So let's say they have a plan. Maybe their plan is to, I want to shoot myself, or I've been thinking about getting a gun and shooting myself. Then you need to ask them, do they have access to that plan? Do they have access to a gun? If they have access to a gun, it's obviously that's very important for us to know, and then we need to, make steps to means that plan is a more lethal plan. We need to take action. If their plan is, well, I feel like taking my car and running it off a bridge into the water. Okay, are there bridges with water around here? Well, in the Quad Cities, there are a lot of bridges and water, so that they very much do have access to it. If you're somewhere out in the middle of, I don't know what state, Kansas or something, there's no rivers or streams or anything around, their lethality of plan goes down a little bit. I don't know how many people that when I've been worked over at Genesis where people have tried to jump off the bridge, either the Centennial, usually it's the Centennial Bridge, or if people say that they have a plan of jumping off the bridge, and usually they'll say the Centennial Bridge. So that's, again, very, very possible because we have so many around here. The next thing we want to do after we know what their plan is, if we know what kind of access they have and that sort of thing, we ask them if they feel that if they feel like they are in control of their actions. Meaning, so you have this plan. Do you feel like you are going to carry this out, or do you feel like you have control and that you won't do that? And you engage them in that discussion. Many times when people say, oh, I would never do that, but this thought just comes into my head that I want to jump off the bridge, or that I want to shoot myself, and I know I could go into my dad's closet and I know where the gun is and that sort of thing, but no, I feel like I'm in control and I would never do that. Okay, so they are expressing, at least to you now, that they feel like they are in control of their actions. There are those people who say, I'm not sure if I can control myself. That's what scares me so much. But we have to engage them in that question. Lethality assessment, I want you to know that very, very well on page 518. I want you to know high lethal, what are high lethal plans and what are low lethal methods. Okay? This is going to predict the likelihood of suicide, of carrying out that suicide. It's also, it helps us assess risk factors, determine if they need hospitalization or precautions, that sort of thing. And I think if you look in your book and turn to page 518, one thing I always ask everybody is anything on that list surprise you, or make you think about, wow, I never would have thought that. For example, a least lethal method is wrist cutting. A lot of people think, oh my gosh, if they're cutting their wrist, then that's definitely that they are going to hurt themselves, or that's going to cause them to kill themselves. Okay, but those actually are less lethal methods. Doesn't mean you couldn't kill yourself that way, but it's just less lethal. Highly lethal methods, I don't know if any of those strike you. Exposure to extreme cold, some of those types of things. Antidepressants, there are certain antidepressants that carry a higher risk if we overdose on those. A gun, obviously, is going to be very high. Jumping off a bridge or jumping off a building, very high. Hanging. I don't know how many recently here that I've read either around the Quad Cities or I've seen, read about or heard about young people that are hanging themselves actually in their houses or around their houses, and they're being successful. One gal from, I think it was maybe 2 or 3 years now. She was a sophomore in high school. She hung herself from, maybe it was down in the basement, hung herself, and was successful at that. Her mom came down and found her. Another boy hung himself out in a park that was really close to their house from a tree. Okay, and both of those were successful. So it is amazing how, those highly lethal methods. So take a look at those, and I want you to know those. Okay, the lethality assessment scale, which is on the green box on page 518. I want you to know that. Okay? This assesses indicators and determines where the client falls on the scale. I want you to know the indicators for each level. All right? So obviously when I say you need to know something, that probably means there's going to be questions on that. So for example, if I gave you a scenario of somebody, I might ask, where does this person fit as far, fit on that scale of a danger to themselves? Are they high risk? Are they moderate? Are they low risk? Are they very high risk? So I want you to look at those very carefully. What distinguishes a person who's low risk from a person who's moderate risk? What distinguishes a patient from high risk to very high risk? So you need to know those distinguishing criteria there with those indicators, all right? All right, getting back to the assessment, objective data, all those signs and symptoms, again, from the first page, you need to know those for objective data. Are they going through, or do they have a history of stressful events? We also want to be interviewing family and significant others to get another viewpoint and to validate or to substantiate what that person is saying. We also want to look for a history of drug abuse or drug addiction. I kind of mentioned this before, but that drug abuse, drug addiction can increase depression, all right? It also can decrease inhibition. And if you remember when we talked about that, so that if have a decrease in inhibition, they may actually then become impulsive and may actually be able to carry out that suicide plan. So you might have a person who is depressed, but then one night they drink and they get drunk, and you see that they take 2 bottles of pills, or they cut their wrist or something like that, because that inhibition is down and they carry out that plan. And again, I don't know how many times I've interviewed people, coming in on the day shift. They've been interviewed, during the night, and they wake up, they've had a chance to sober up and that kind of stuff, and they say, oh, I can't believe I took those pills, or I can't believe I did that. If I wasn't drunk, there's no way I would have ever done that. I'm not that type of person to overdose on pills, or I'm not that type of person to cut my wrist, but, so now the danger with that is that decreased inhibition, maybe accidentally that person actually takes too many pills and kills himself, or maybe they cut themselves deep enough, or whatever. So that history of drug abuse and addiction is very important when we're looking at depression, but also when we're looking at suicide lethality. All right. Okay, so now we're going to continue with the nursing process, looking at the nursing diagnoses, outcome, and nursing intervention for depression. First one we have here is risk for self-directed violence. And just to be aware that this, or we could say self-directed violence or self-harm, this is always going to be our priority, because it is a danger to themselves. This person, somebody who is at risk for self-directed violence, usually feels very worthless, helpless, and hopeless. The outcome starts here on page 519 in your book. But if you think about what would be the opposite for risk of self-directed violence when we were talking about outcomes, one could be the patient will not harm self while in the hospital. And then we need to think about behaviors that demonstrate patient understanding of the self and behaviors. That would be another outcome. Another outcome could also be patient will acknowledge suicidal thoughts and self-harm behavior. And again, that's measurable because they're able to acknowledge those suicidal thoughts, and they're able to acknowledge that, yes, I have those, yes, I have self-harm behavior. Another outcome might be the patient will identify triggers, and that's something then that you can help them think about. What are those triggers to when I might start to feel suicidal? A trigger might be when I start to think about how worthless I feel, or when I start to think about trauma that I had in my childhood, and that makes me feel worthless. So it could be a lot of different triggers. Also, another trigger could be possibly I'll never be able to do better or my parents will never accept me. Those, again, might just be triggers. Another outcome might be patient will identify and tolerate bad feelings. One of the things that we have to understand is that many times we all have bad feelings in our lives. All have, really negative feelings at times. But if we have healthy coping and if we have a healthy self-esteem, we're usually able to tolerate those bad feelings, and oftentimes able to, consciously think our changing and think about how we can change, those feelings. But many times people who are very suicidal, very depressed, have a difficult time tolerating those bad feelings. They're just too painful and they just can't deal with them. They have no way to problem solve out of those and feel helpless and hopeless with those feelings. We could also say that another outcome might be patient will demonstrate behaviors that, or will have behaviors that demonstrate development of new coping mechanisms. And then we could list those new coping mechanisms. Or patient will choose alternatives to negative thinking and acting out on suicidal thoughts. And then, for example, calling a friend, journaling, changing their negative to thinking to positive thinking. So when we're looking at this risk for self-directed violence, this nursing diagnosis, we, and as we're writing outcomes, some of the things that we want to see or signs that are going to point to clinical improvement is that if the patient is able to verbalize coping mechanisms, or how healthy coping mechanisms that is, if the patient is able to make long-term plans, look out into the future, that shows a sign, or that is a sign of clinical improvement. If the patient is able to verbalize hopes in the future, hopes for a career, hopes for a family, or hope for a job, that sort of thing. Verbalizing hopes also indicate improvement. Reconnecting with family members or significant others, trying to rebuild relationships, that can also be a sign of clinical improvement. If the patient has more energy, if they're able to sleep better, if they can verbalize decrease hopelessness, all of that is going to indicate or a sign of improvement, and those are the outcomes that we want to see. Okay, so interventions here. Obviously, we want to prevent suicide, and always we want to promote safety as the top priority. And I do want you to know the general guidelines for suicide prevention, and on page 519 to 521 I want you to know those bullet points. I also want you to be looking at the suicide precautions on page 521 in that purple box. Again, I'm not going to list all of those here, but to know those bullet points. And monitor for safety of the therapeutic environment, page 522. Some of those things that I already talked about in when we were talking about schizophrenia, about how to create a safe environment. Doing every 5-minute checks if you're on the acute or locked unit. And maybe when they're on the open unit, that's going to change to every 15 minutes. All of those environmental things that we already talked about, as far as no glass on the unit, no having curtain rods or shower rods that break, hooks that break, that are breakaway. Furniture that doesn't have any sharp edges. Many times when these people are checked into the unit, all of their belongings are searched, and anything that is considered a sharp or something that could be dangerous, those are locked up in the patient's closet. So, for example, if they brought a razor in with them for shaving, that would be locked up. If they brought possibly belts and they were on the acute or the locked unit, that would be locked up. Many times locked units will have patients, the only thing they can wear is slippers, so all their shoes are locked up, usually because the potential, if they have shoelaces, that those possibly could be used. So those are a few examples. So I want you to know those general guidelines, suicide precautions, monitoring the safety of the environment on page 522. Frequent suicide assessments should be done depending on the status of the patient. So, for example, if they are on the locked unit, we should be doing a suicide assessment along with the mental status exam probably every 4 hours at a minimum, and possibly more. And that suicide assessment is going to include, are you having thoughts right now of wanting to hurt yourself? And if they say yes, again, then we just follow that assessment. Are you having, tell me what you are, exactly what you're thinking about. Is there a plan? And to follow, asking them what the plan is, and then asking them, are you feeling like you're in control of your actions right now, or do you feel like you're out of control of your actions? Okay, moving on. Also, with this nursing diagnosis, it's important that we spend one-to-one time with them and counseling one-to-ones with them, working towards those outcomes that I mentioned before. Really encouraging them to verbalize about their feelings, about the circumstances of their possible previous suicide attempt or suicidal ideation. But we want to help them acknowledge their suicidal thoughts or self-harm behavior, all those things I mentioned before. Help them to identify triggers, help them to talk about feelings and work on tolerating those, work on coping mechanisms. So that's what we're doing there. We're also assessing for signs and symptoms of improvement, as I just discussed about those signs of clinical improvement. In depression, we know that somebody is improving if those symptoms that they came in with are improving. So, for example, if one of their main symptoms was that they were only getting 2 hours of sleep, we know that they're going to be improving if they start to get 4 hours of sleep, 5 hours of sleep. If they're able, again, depending on what they came in with, if they're able to concentrate better, if they have better energy, all of those will indicate improvement. We can also use a no self-harm contract, and that's on page 519. This can provide, as an intervention that can provide additional support. It can be a verbal contract or a written contract. And basically what this is a promise that the patient is stating that they are not going to harm themselves, and usually we put a time period on it, so for the next 8 hours or for the next 4 hours. So they promise that. And if they feel like they are having thoughts and they cannot control those actions, that they will come and let the nurse know. And this intervention has proven to have good outcomes, especially if there is trust built in that relationship that you have with the client, and the client is making good eye contact with you. So basically we ask them to say, I know you're having suicidal thoughts right now, but I'd like you to make a no self-harm contract with me. Can you promise to me that you will not harm yourself for the next 4 hours, or whatever you want to put in there, the next 8 hours? But if you do feel like, if you're having thoughts and you do feel like wanting to act out and you don't feel like you have control, can you promise to come up and tell me and talk to me about that? And if the patient is able to repeat what I said, I promise, etc., etc., then we can chart that patient is able to make a no self-harm contract. I also want you to know the intervention boxes on page 419 and on page 631. As the client starts to improve, and when the client or patient is able to say, no, I'm not having any more suicidal thoughts, then suicide precautions can be removed. One thing to know, as the client begins to improve, say if their depression is starting to improve, it's possible that the risk of suicide may increase temporarily, especially if the patient has an increased energy, and that might just give them an increased ability to act on their suicidal ideation. This is something we talk about, especially with medications. Medications, as a patient starts their medications, it's very important that we continue to monitor that suicide risk, because as their depression improves, they might have better energy, they might be thinking clearer, but they still might have those suicidal thoughts. So they might just then have the energy to carry out a suicidal plan. So even if we think that they're improving and getting better, we still need to be assessing that risk for suicide. As I mentioned, I kind of mentioned this before, but other interventions encourage discussion of feelings. whatever those feelings are, anger, hopelessness, help them to accept those feelings. And the more they're able to accept that, talk about it, that hopefully is then going to prevent them from acting out on them. And we also want to encourage positive coping mechanisms and different ways to cope with those hopeless feelings, those helpless feelings, so that they have more options than just thinking about suicide and carrying out suicide. Another intervention, we can teach relaxation techniques as a coping mechanism to deal with whatever feeling, whether it's anger or hopelessness, that a person will have prior to those suicidal thoughts or suicidal feelings. And relaxation techniques could be progressive muscle relaxation, it could be deep breathing, it could be guided imagery, it could, journaling is more of a different intervention, but some people describe that they feel much more relaxed when they are writing in a journal. It could be listening to music, so a wide variety of relaxation techniques. We also want to work with the families. And page 522 and 523, also page 633 talks about this. There's the green boxes that I want you to read about that talks about helping families prevent suicide. We also want to help them look at community resources, especially when they're discharge planning, making sure that on discharge we give them a crisis phone number so that if they are feeling out of control, are having thoughts of suicide, that they know where to call. Also, many psychiatric units will also give patients the unit phone number or the emergency room phone number so that they feel like they have some place to call. In discharge planning, we work with the patient and sometimes the family to develop a suicide crisis plan, so that if I am feeling suicidal, or if a family member knows their daughter or son is feeling suicidal, what is that plan? Calling the hotline, or staying with that person for 24 hours, or getting somebody to stay with me for 24 hours until I can get help. But we talk specifically about what will be the suicide crisis plan. Again, I talked about a crisis line, educating the family. We talked about this with schizophrenia, but it's very important that we help family members and patient recognize early warning signs and cues of depression and moving towards suicide, so that those can be recognized early and caught early, and so the patient can go and seek help early before it gets to the point where they are carrying out a suicide plan. Okay, the next nursing diagnosis is disturbance in self-esteem. The outcome here, if you think about what is the opposite of a disturbance in self-esteem or a poor self-esteem, would be a judgment of self-worth. Basically, increased self-esteem, right? But what would be a better way to write that? But patient is able to judges themselves as worthy. There's a variety of ways that you can, say that, but judgment of self-worth. Verbalizing self-worth, verbalizing and taking care of themselves indicates an increased self-esteem. So if I'm talking about, yes, I deserve to be in a good relationship, or I deserve to have people treat me well, or if I deserve to be able to make a living and to work at a job, those are that's verbalizing self-worth. If they're taking care of themselves, if they're starting to take care of their grooming, starting to take interest in their ADLs, that also shows a judgment of self-worth. Interventions here is we want to promote self-esteem. And if I have page 375 on there, you can cross that out, but to promote self-esteem. So we want to, one of the things that we can do is provide distractions, especially if they're doing a lot of, if they're very self-absorbed and are always thinking about how bad they are, how worthless they are, that sort of thing. And there is a time that we need to talk about those feelings and work on those feelings, but many times a good intervention is to provide distractions, to get them away sometimes from those thoughts. Simple activities might be walking, exercising, doing some hobbies. At times we may need to force the person to, or we may need to talk to the patient about forcing themselves to do activities. Even when you're depressed, even when you don't feel like doing something, if you force yourself to do that, many times that leads to feeling better. And doing those things that we might not want to do, forcing ourselves, again, not just waiting until we feel better, but forcing ourselves to do it even when we don't feel better. So maybe we don't feel like getting out of bed and fixing breakfast and taking a shower. Forcing ourselves to do that is going to lead towards that, to making us feel better and help with that. We need to help the patient recognize accomplishments that they have, positive things that they're going on in their life, and to do that in a positive manner, in a matter-of-fact manner. We don't want to flatter them and just say, oh, you're a wonderful person, or look all these positive things that you have, but to matter-of-factly, let's think about what are some of those positive things that you have going on in your life, and help them to come up with that themselves. And if they are able to look at that, that will also encourage, positive behavior. Helping the patient identify personal strengths, that's kind of along those lines of accomplishments. Don't just tell them what their strengths are, because we may be able to see them, quite obvious, and list them all down for them. But during a one-to-one in counseling, help them identify that themselves. Okay? Accepting, it's important for us to have an accepting attitude, but we might need to set limits on negative thinking, and try to identify if they're having a lot of patterns of negative thinking. Some people, if we would allow that, would just go on and talk about negative things. And sometimes we might need to say, okay, well, we have a 30-minute time block here. Why don't, and we know if we're noticing them talking about a lot about negative things, we might say, we've been talking a lot about negative things here. Why don't, we can talk about this issue for about 5 more minutes, but then I want to move on to talking about some other things. And so that, we're setting a limit. We're not allowing them just to talk about negative things for the whole 30 minutes, but we put a time limit on that. And we can do that very professionally, therapeutically, and kindly. We also want to teach assertive communication. Many people who have poor self-esteem have a very passive way of communicating and an unassertive way of communicating. Teaching assertiveness, teaching people to say no to protect their own rights is something that not everybody learns, and this may be something, if we identify this lack of assertiveness, that may need to be taught. The person may have a history of being taken advantage of by people around them. And again, this might be an indication that they need to have be taught what assertiveness means, how to communicate assertively, how to stand up for my own rights, how to say no to others, and to teach them that they are an important person and they have rights, and they have a right to stand up for their rights. Okay? All right. So again, one of the things, another intervention kind of along this way, is we can look at patterns of their thinking, and what are their thinking patterns? Is there a lot of negative thinking patterns and that sort of thing, and then to work on those. Okay, the next intervention, or the next, sorry. Okay, so the next intervention is next nursing diagnosis is social isolation. And again, the outcome, what is the opposite of social isolation? But it may be patient will be more involved in social activities on a daily basis on the psychiatric unit. You may want to be very, specific, such as patient will attend one group per day, or one group with the faculty or with the staff person a day, and it may increase. Then after 2 days, you may have the patient go to 2 groups per day. Again, individualizing that to the client. Another outcome might be that patient will accept support from others and allow people to talk with them, allow people to give them encouragement. Another one might be patient will verbalize a decreased loneliness. Patient will be able to use appropriate interactions with peers. And then you might want to show what those appropriate interactions are. Watching TV with other people, introducing themselves to new patients. So to be able to, put those down. And it could be, the time frame could be on a daily basis. Interventions for social isolation. If a person is feeling very, very, very isolated, it may be that we need to start out with brief, frequent contacts and make sure that we're showing interest in the patient. We do have those patients that are so isolated that it is very, very difficult to have them come out of their room. And it may even be very difficult for them to want to visit even with a staff person. So many times as we build trust, brief, frequent contacts can be more successful. And the fact that we're taking the staff person is taking the initiation and showing interest in the client and building trust. This is also a time where we can allow for silence. Silence can very much convey acceptance of the patient, non-judgmentalism, but I will accept you even if you want to be quiet, even if you're feeling like you don't want to talk. I can sit here with you in silence, okay, until you feel like you're talking or until you feel more trustful. Okay, so silence is important, non-judgmental, like I said. Again, encouraging the patient to express their feelings and in a healthy expression. Talking about their feelings, not just sitting around ruminating in their room, but encouraging that healthy expression of feelings. And I mentioned this before, but when they're comfortable interacting maybe with one staff person, we start to encourage maybe some group activities on the unit. And maybe you're going to attend the group with the patient at first, and then gradually they'll start to attend by themselves. But we also want to create activities for them to learn and practice social skills, much like we had talked about with individuals with schizophrenia. How to make friends, how to make small talk, how to be assertive. Those are all things that play a part in that. The next intervention is hopelessness, and we could include powerlessness in there. The outcome here is that we want the opposite. And what are some ways that would show us that a person is hopeful? Okay. One outcome might be that patient is able to make decisions for themselves, or there's an increased ability to make decisions. Again, that is going to mean if I'm making decisions, that means that I'm looking forward to the future, and I'm caring about what might be happening to myself. Patient will be able to verbalize hope, and optimism is also another outcome that would indicate a decrease in hopelessness. Mood equilibrium, and that's just that a patient's mood may increase, and we can know if a depression is decreasing by many of those symptoms that we talked about on the first page. Patient expresses satisfaction with their quality of life. That is another outcome, that they are happy with what's going, and verbalizing happiness or satisfaction with how things are going on in their life or areas in their life. Interventions here, we want to help them develop a positive outlook and avoid maladaptive dependence on other people or on other things. We want to help them exert self-control with our interventions. So again, one-to-one relationship, having one-to-ones with that patient where we're counseling them and assisting them in developing a positive outlook. And this is where cognitive therapy plays a big role. Helping them look at what their thoughts are and examining, are those positive thoughts or are those negative thoughts? And then talking about, how negative thoughts lead to negative feelings and hopeless feelings, and how if we can change those negative feelings to positive feelings, how that can help them. Providing and evaluating responsibility, encouraging them to plan their own care, encouraging them to take part in those daily routines, setting realistic goals. What are some of the things that they want to accomplish in their life, or what are some things that they want to accomplish, in the next week? How can we break those down into smaller goals? Help the patient identify ways to gain self-control, and that might be in a relationship and outside of the hospital. This also leads to increased hope. For example, my mom always tells me what to do. And how can they gain more self-control in that relationship? Well, maybe you need to, to help them and coaching them how to talk with their mom about that. How can we be assertive and tell your mom that, I need to make some of my own decisions? So that's just kind of one example. Or if a patient says, I'm in a dead-end job, okay, and they feel like they have no control over that. That's just their lot in life. There's nothing they can do to change. Well, we gently challenge some of these thoughts and help them think about things in a different way. We want to teach problem-solving techniques. It may be that they feel so hopeless that they don't have any, or feel helpless that they don't know how to take an active role in their life. If they're making decisions, can you make a pro and con list? Okay, can we look at ways to make decisions? So help them with that. Identifying things that can't be changed. Sometimes in life there are things that can't be changed, and we might need to accept these and work around these. But there are many things that we can change. And then again, helping them look at community resources and how to build support systems in their environment. Those support systems might be therapy groups, therapy support groups. They might be social groups, volunteer groups, church groups. But those can be very helpful in building hope and in encouraging hope for a person.